Hello, welcome to the JASN monthly podcast. I'm Josie Briggs. I'm editor-in-chief of the journal, and each month I do a short podcast to talk about papers that I think are of special interest in each issue. Today I'm going to talk about a manuscript that's actually featured on the cover of JASN, and so those of you who receive this issue in your mailbox, look at the cover figure. It is taken from a manuscript entitled Immunosuppressant Medication Use in Patients with Kidney Allograft Failure, a prospective multi-center Canadian cohort study. First author is Greg Noel. The senior author is John Gill. Now, all of you who take care of transplant patients know that one of the tough situations in which there are difficult clinical decisions to make are in patients who have had a failed allograft. Most of these people are listed for a second kidney, but the question of how to manage immunosuppressant medication in that waiting period is a tough one, about which there's not enough evidence to judge all the tough decisions that need to be made. The figure you see on the cover shows the data from a large cohort of Canadian patients whose grafts failed. And the blue bars show that most of these patients were kept on prednisone, generally of relatively low doses, but the other medications, cyclosporin or Tacro and mycophenolate, were tapered rather rapidly, so that by 2 years, most patients were off immunosuppressants. In this prospective study, the authors found, following this group of about 270 patients for an average of about 2 years, that to what I think would be a surprise, the continuation of all immunosuppressant medication was associated with a lower risk of death, probably because of suppression of inflammation or allograft failure. The hazard ratio was 0.4, although the confidence intervals were wide, 0.17 to 0.93. The difference in death rate was highly significant. Continued use of immunosuppressant was not associated with a higher risk of hospitalization, in spite of the concern that this would result in greater rates of infection, and it was not found to be protective of rejection of the failed allograft. As expected, anti-HLA antibodies increased during follow-up, but they were not clearly at 1 year or 2 years different in the groups who were continued on immunosuppressants and those who were discontinued. So these interesting findings challenge current recommendations to discontinue immunosuppressant medication 1 year after allograft failure. Quite paradoxically, they raise concerns that the current prolonged use of immunosuppressants after transplant failure, at least in this subgroup of Canadian patients, may not be of sufficient intensity to prevent rejection and sensitization. We viewed at JASN that this is an important paper. Now, it is important to also add that this observational study findings do not provide the definitive evidence that we would all like as clinicians to know what the optimum duration of treatment with immunosuppression medication after transplant failure. But they do bring into question the current recommendations, and I think these are questions that every transplant doctor will face and have to struggle with. I as a journal editor, want to emphasize that this is clearly a good question to study, and it indicates the need for a well-done prospective controlled trial. So take a look at this issue of JASN. I think you'll find this study to be of interest, and I hope you'll continue to look at the issue each month and find things of interest for you, for your practice or your research. Thank you, and that's the end of this short podcast.
This podcast is copyrighted by the American Society of Nephrology, all rights reserved. All content in this podcast is for informational purposes only and is not intended to be medical advice. This podcast should not be used in a medical emergency or for the diagnosis or treatment of any medical condition. Please consult your doctor or other qualified healthcare provider if you have any questions about any medical condition or before taking any drug, changing your diet, or commencing or discontinuing any course of treatment. Thank you for listening to this podcast from the American Society of Nephrology.